Well, thanks for being here tonight to everybody who's been here. So we have listened to all your comments and we've made changes and we promise we're going to evolve this as we go along. Having said that, this is your journey. We're hoping to be part of your journey so we can make it better for you as you progress through your career in community oncology and eventually become leaders. So I have asked for all of you tonight. We can only make this better if we get more feedback. I really need more feedback. The more criticisms that you can give me, we can make this program better. And I can promise you we'll listen to every criticism, negative and positive, as we go along. We're learning from this. We're hoping you're learning from this. So that's my ask from all of you tonight. I need at least 2 to 3 questions from all of you during all of these sessions. And then please, I need the feedback at the end of the night. I do not care if you're going to put a finger right in my eye and tell me that something sucks. That's okay. I still need the feedback. We're lacking in feedback. Having said that, the 4 speakers we have today, I'm very excited. I'm sure all of you are going to learn a lot tonight. Josh Cox is probably one of the best pharmacy guys in the country, leader in his field. He'll teach you a lot. Go ahead and ask him your best questions you can. Gary Branning, I've heard a lot from Joel Schredler. I'm sure he'll be a big asset to this program tonight. And then finally, hopefully, Patrick Rollins is going to tell you about how to not to lose money. And then for me, the biggest one is understanding the financial sector and how to think about in the financial sector. I think it'll be helpful for all of us. So that's the program we have tonight. I'm very excited. I'm sure all of us are going to learn a lot. Next slide. So these are the key issues and challenges that I'm looking forward to community oncology and my own practice and practice across the country facing in 2022 and 2023. Number one is the CMS sequestration cuts are coming. If Congress doesn't act, that means a 1 to 1.5% cut in your reimbursement for your drugs. That translates to roughly about 4 to 6% of your income. So this is something where you need to be involved in boards across the country, lobbying groups across the country, whichever one you support, whether it's the ASCO, the ASH, COA, whatever your favorite body is, to help move this to Congress, to tell them how important it is. What does community oncology mean? How many patients do we treat in the community? And be out there. You're doing this for yourself. And more importantly, you're doing it for your patients who can get quality care right next to their home. So CMS sequestration cuts is a big one. And I want you to be involved in the activism and going to those meetings and lobbying, speaking to your congressman, your senator in your local area. Number 2, for radiation oncology, if you're part of a big cancer center, there's a huge reduction in payments coming in, mostly because of cuts for IMRT. Right-sided breast IMRT probably will go away by the next 2 to 3 years completely. Prostate cancer IMRT is probably going to disappear fairly soon. That again will hit into a community cancer center and the way you're providing services to your patients. Number 3, OCM, as you all know, is done. So CMS has come out with this enhanced oncology model. I'm going to share a few slides to give you just a brief highlights. All of you will be presented this in your practice. So I don't want any of you to look stupid when you get presented this data. I want all of you to know at least some basic understanding of what is expected in the EOM and what your practice is going to expect you to do. And more importantly, what is CMS expecting your practice to do? So that's a big one. And lastly, again, one of the biggest challenges to community oncology is the hospitals and their 340B and a very unfair pricing program. And Josh will probably talk about this at some point about the pricing and the 340B program and what we get challenged with. Just to give you an idea, for the hospital, which is a 340B program, they get paid, roughly speaking, on an average about $750,000 per year per oncologist. So if you think you're going to compete with that from a community oncology standpoint, it becomes very, very difficult. Obviously, they do not know how to manage their bottom line, so not all of that get translated into physician income or provider incomes, but it's still a big barrier for community oncology. Next. The financial issues challenges, which I think the financial guys will be talking to you. One of the things which is very relevant for you from a personal standpoint and a professional standpoint is there is a new rising interest rate environment. Not most of us in this field who have been in the business field or in the personal field have been used to this over the last 10 years with the interest rates being so low. So this is now going to start hitting us in the next 2 to 3 years. is going to have an impact on your practice real estate, how you fund them, how you refund it, all of those. Same thing with your house loans and personal real estate. And bless your heart, hopefully none of you have credit card loans, but if you do, that's going to get hit too at some point. Next is the stock market issues, and I'm happy we have a couple of sessions tonight. Number one is how to get through a bear market crash and recovery. I've lived through 4 bear market crashes and recoveries in my lifetime as an investor. The bond market changes, and how can you be investing there and partaking of some of the improvements that you may see because of the changing interest rate structure. There are going to be some important congressional changes regarding capital gain structures and estate tax changes, which I'll hope to discuss at a future meeting. Next. This is the first thing, and I think Josh will talk about this soon. This is the changing of the oncology medication landscape that you better get used to soon. So as you can see, the number of pipeline drugs are increasing rapidly. This is from 2021 to 2026. On the right side is the payment of the drugs by Part B and Part D. And as you can see, in a space of about 5 years, there's going to be a drop in the Part D payments by about 7% and increase in Part B. Big transition from injectable drugs to oral drugs going to continue to happen over time, and this will also impact some of these numbers. Next. This is a change in the payer landscape. As you know, your whole practice is a triangle. You're sitting in the middle of the triangle. On the 3 sides of the triangle, you got the patient, who is the most important aspect of the triangle. On the other side is the payer, probably the next important part. And the third part is the pharma. And the pharma industry is undergoing a big, huge change. On the left side, I put down what we're seeing as today's biopharma oncology market overview. And on the right side is what's going to happen by 2026. Large players, huge ones, such as Johnson & Johnson and Roche, are expected to take over the market. And in the smaller space, there's going to be a lot of small companies which will join together. Some of the ones which have been projected to grow very quickly would be Exelixis, Astellas. This is by no means a stock market recommendation. Please don't go and start buying stocks on any of these. The other guys will come and tell you what to do. This is just our projection of where we think the market is heading, where is consolidation, where's the acquisitions coming in within oncology space in the next 5 years. Next. These are things that will impact us. And on the right side, as you can see, I put the big circles just to give you an idea of what is catastrophic, what is significant, what is moderate, and what is limited. And on the left side, I put down the things there. And the ones in blue are the policy disruptors. These are things which Congress can change on you, and you have no control of this. So this is a policy change which you just have to live with and see how can you steer yourself through this. Next, the one in the gray with the orange around it is the commercial payer disruptions. These are again things you have very, very limited control on. These are payers who will be putting in things like closed networks, APM programs, payer care delivery, integration of networks and such. And finally, there are things which you cannot predict, which I've kept it in an invisible one. If any of you can see that, that's good for you. I'm just joking. I don't know. There are things which we don't know about, right? So what are the big things on the congressional landscape that's going to change our way we practice? Number one is the enhanced oncology model, the EOM. I'm going to present about 3 or 4 slides just to give you an idea of what's coming in EOM. The OCM has been closed. Next one is the physician fee schedule changes. I talked about that a little bit. There's a huge widening of the 340B gap through the hospitals. I talked about that. There's a congressional enabled direct drug pricing negotiation scheme that's going to come out. And then finally, the white bagging and the payer steerage legislation is going through. Hopefully that does not pass in Congress. There's a big lobby going against it. We're hoping that will not happen because that might be a death knell to community oncology if there's white bagging allowed, and that'll allow payers to do whatever they want. Now, coming to the payer standpoint, we have the payer steerage to closed networks. Now, that's again something we'll need to fight across community oncology. APM programs, accelerated payer care delivery, which has its pluses and minuses. And then finally, medical to pharmacy benefits conversion. I think Josh will probably talk about PBMs, pharmacy benefit managers, and how they affect private practice and community oncology. But those are all things which can be a huge disruption to the way we practice community oncology today. Next. This is the other problem that we're challenged with. Every commercial payer has his own way of looking at things and how he wants us to practice oncology. And none of them have a clue about how we practice oncology and how this can really be, there can be uniformity. They think we can bring in uniformity. These are what we have been presented in Iron Road in the last 2 years. I just put these up there so you can see. Optum wants something called the Cancer Guidance Program. Humana wants the oncology model of care. Then there's Oncology Medical Home by Blue Cross Blue Shield and Aetna. And then Cigna has a Pathwell program. And finally, there's administrative friction between all of these because we're using biosimilars and storing 20 different biosimilars because there's no uniformity across all the commercial payers. So we just need to practice some best pathways that we can steer through all of this. Next. So what is the enhanced oncology model? Very briefly, I'm going to present this in about 3 to 4 slides. So what CMS did, they wanted to build on OCM lessons that they learned, and they wanted to continue to practice value-based care in oncology. Now that would mean reducing the cost of care. The very next thing they have on their agenda is the Cancer Moonshot program, which will increase the cost of care. So they kind of go in conflict to each other. President Biden has a very, very ambitious agenda called the Unity Agenda to improve the care and make every drug accessible to everybody. So yes, that will increase the cost of care, whereas the first one is trying to reduce the cost of care. And then finally, the CMS Innovation Center decided that they needed a whole strategy refresh. That's why they took a timeout, and this program will not roll out till July of 2023. Next. So what are the key issues with EOM? It should be a Medicare enrolled physician group practice with a unique tax identification number. Can you go back? Sorry. Okay. This is interesting. They're allowing commercial payers to come in, not just in the setting of advantage plans, which we're used to in the past, but regular commercial payers can be partners with CMS. I haven't seen much data on this yet, so I'm waiting to see what that means to us. The cancer types which are going to be included in the data collection are the usual suspects, the big 3, breast, prostate, colorectal cancer, and lung cancer. Then you've got the leukemia, lymphoma, myeloma. So things we have been used to. We have followed this in OCM, so hopefully it should be easy enough for us. What they think the key benefits would be care transformation, whole person, patient-centered care. That's big on their agenda. Benefit enhancements with telehealth, post-discharge, home visits to the patients. Still waiting to see who's going to fund that or how much we're allowed to carve out for that. Advanced health equity and disparity. They want to cut down the disparity that exists in the current model. I think all of these are very lofty goals. Hopefully we can advance this over the next 10 years. Next. So what does it mean to us from a financial standpoint? Number one, there are 2 financial incentives. So for those of you who are familiar with the terminology, the first one is MEOS, M-E-O-S. That's a monthly enhanced oncology services payment based on the care mix of patients that we have and the quality of care that we provide. And then finally, there's retrospective performance-based payment or PBPs or recoupment if you're not done well, which is PBR. That can be scary. And then what they want essentially out of this is a 24/7 access to all the medical records to all the physicians, which hopefully most of your practices have already done with OCM. Patient navigation, that's a challenge because hiring patient navigators can be very difficult. So sometimes patients do get, very difficult for them to get access to care. So certainly it's a very good goal to have. Care plans, which they want to be uniformity. Luckily with the NCCN, they're willing to accept NCCN as being standard of care there. So that is good. Clinical guidelines. And finally, they want to develop this health-related social needs. So we're trying to find out more about this as to what we can do. It's just not your PHX-9 form that you're used to. This is quite different. They want us to increase psychological delivery, social workers, all of that. Next. And what they're promising in addition to what we had in OCM is that one of the things with OCM was the data was so delayed, we could not react in time. So now they're saying they'll be much more reactive and provide this data much faster to us. So this is going to include quarterly feedback reports rather than having to wait 6 months for the data to come out, semi-annual reconciliation so we can move past the data and move on to the next 6 months, and monthly claims data, which we were not getting as well with OCM. So all of this, they promise to deliver from their back end, which is why they're taking a refresh for about another 6 more months. Next. Yes, I think that's my last slide. I'll pass it on to the next speaker. Thanks.